So vascular imaging, and we will start with the aorta. Very shortly, we will start with anatomy, and then we'll start with some pathologies in relation to imaging. So not just pathologies. So the aorta. We have some variants in the aorta, but let's start with normal anatomy. When we are talking about the anatomy of the aorta, we are looking on the ascending aorta, the arch of the aorta, and descending aorta and abdominal aorta. I will talk about mainly now the superior part, where the ascending aorta coming from the heart, left atrium, then the ascending aorta, this ascending aorta, arch of aorta, descending aorta, and abdominal aorta. Those are the parts. Now, when we are talking about the arch of the aorta, we have the normal branches from the arch, and there are anatomical variants. So let's start to talk about the normal anatomy. So the normal anatomy, let's call it of the branches of the aorta. So again, we have the ascending, arch, and descending. Now in the aortic arch, in this area, we have the brachiocephalic branch, which divides to become the right common carotid artery. Right common carotid artery. We have the right vertebra. We have the thyroid cervical artery. This is the right subclavian. The internal mammary that comes right over here. Internal mammary. Okay, you see that the right side, this is the right side, what we just did, starts with the brachiocephalic artery. Now, when we're talking about the left side, we won't have this brachiocephalic branch. We will have its branches coming immediately from the arch of the aorta. So here we have the left common carotid artery, just right over here. And you remember that the common carotid artery will split to become the internal and external carotid artery. But anyway, here it's the left common carotid artery. This is the right common carotid, this is the left common carotid. You see the right common carotid comes from the brachiocephalic, and the left common carotid branches immediately from the arch of the aorta itself. Now we have the left subclavian, which comes from here, and this is the left subclavian artery. This is the right subclavian artery. Now from the left subclavian artery, as from the right side, but without the right common carotid artery, we have its branches. We have the internal mammary, like on the right side. We have the left vertebral, like the right vertebral, and we have the thyroid cervical artery. And this is the branches from the arch of the aorta, the normal anatomy. Normal anatomy that usually is seen in 66% of the patients. We see this normal anatomy without any variance, this is the normal anatomy. Now, the next thing that we will do is looking on variance. So let's look on variance of the anatomy, or more accurately saying, the branches. So again, we start with the normal ascending arch and descending. Just let's do it a little bit. Okay, this is better. You see the ascending arch and descending, but now I will talk about different type of branches, different ways of branching from the arch of the aorta. So we'll talk about we'll start with common origin of the brachiocephalic artery and left common carotid artery. So common origin of brachiocephalic and left common carotid. Namely, we have the brachiocephalic and all its branches, the right common carotid, the right vertebral, the mammary and everything. This is the right subclavian. But from here, you see the left common carotid. It comes from the brachiocephalic artery. And here, of course, you see the left subclavian artery with its left vertebral. This is the unique part. Instead, coming straight from the arch of the aorta, it doesn't happen. It doesn't happen, as usually it does, but it comes from the brachiocephalic, which again, brachiocephalic should only come from the right branches of the arteries from the aorta, from the arch of the aorta. Now, let's continue to another anatomical variant, which is called the aberrant right subclavian. The aberrant right subclavian. Aberrant right subclavian. Okay? Now, on aberrant right subclavian, we have the right subclavian artery coming from a different place from the arch of the aorta. We have the right common carotid comes straight from the arch of the aorta, what should not happen. The left common carotid comes straight from the arch of the aorta, which is usually the case. We have the left subclavian artery, comes from the arch of the aorta, totally normal, and the left vertebral artery coming from the left subclavian artery, totally normal. But now we have the right subclavian artery coming right over here and crossing to the other side. This is the right subclavian artery. In this aberrant right subclavian, this is the case. You see how it comes from the left side. And here comes the right vertebral artery, right over here. This is the aberrant right subclavian artery. Now, when we're talking about the common origin of the brachiocephalic and the left common carotid, we see this case on 30% of cases. And this case of the aberrant right subclavian, which we can see right over here, is like in 1% of cases. Usually, the right subclavian artery doesn't cause symptoms, but it should be noted because it is important for surgery, and it is important because sometimes it goes near the esophagus, and sometimes it can compress it and present with dysphagia. So it may cause symptoms even though it is usually asymptomatic. Now, it may cause dysphagia. It may also cause problems in thyroid surgery. In thyroid surgery, when there is right subclavian artery, the pathway or the position of the recurrent laryngeal nerve will not be in its usual location. So in this case, the recurrent laryngeal nerve in abnormal position, let's call it abnormal position. So it's important to notify it, especially if the patient is going to have thyroid surgery or neck surgeries or everything that may cause problems with anatomy of this area, especially thyroid, because the recurrent laryngeal nerve is important in those surgeries. Okay. Now, there is another variant, maybe the last variant we're going to talk about, which is the left vertebral region of the aorta. So let's call it the left vertebral origin of it going from the aorta. What I mean by that is that if we again look on our imaging on the arch of the aorta, we have the normal brachiocephalic coming right over here, going to be the right subclavian artery. So brachiocephalic, right subclavian, normal, right vertebral, normal. Maybe I should do it more distally, right over here. Right vertebral, totally normal. Right common carotid, totally normal. Yet we have the left common carotid again coming straight from the arch of the aorta, which is normal, but here we have something that is not normal. This is the left vertebral artery, which should or usually comes from the left subclavian, but here it comes straight off from the arch of the aorta, and here is the left subclavian artery without giving the branch that is missing right over here. Where is the left vertebral artery? It's not coming from the subclavian, the left subclavian artery. This is this anatomical variant. Now you see that there are 1, 2, 3, 4 vessels coming from the arch of the aorta. 4 vessel. So it also sometimes called 4 vessel arch. 4 vessel arch, because of the 4 vessels coming from the arch of the aorta. Sometimes in this variant, the vertebral artery terminates as the posterior inferior cerebral artery, named PICA in short, instead of contributing to the circle of Willis as the vertebral artery should continue. Vertebral arteries continues to form the basilar artery, and before this they give off the posterior inferior cerebral arteries, or right? Wait, because if I will remind you the circle of Willis, what we will see, let's just remember the circle of Willis. This is a very important subject, so let's remind this very important thing. We have the anterior spinal artery coming to its side, the vertebral arteries in each side. We have the right vertebral artery and the left vertebral artery, but here posterior inferior cerebellar artery coming from here. Posterior inferior cerebral artery, posterior inferior cerebral artery, and the vertebral artery should not stop by the PICA. It should continue coming together, forming the basilar artery, then the superior cerebral artery, then giving the posterior cerebellar artery. Then we are having the posterior communicating artery, coming to the internal carotid that give off the MCA. So this is the internal carotid artery, and this is the MCA, middle cerebral artery, giving off the anterior cerebral artery, and then the anterior communicating that comes right here, anterior communicating artery, and here is the anterior cerebral artery, and here is also this, and this calls the same. So you see, this is the circle of Willis. The same goes for the other side. Posterior cerebral artery, middle cerebral artery, internal carotid comes from here, and this is the anterior cerebral artery, and here we have the anterior communicating artery that comes right over here, and this is the circle of Willis with a very bad artistic style, but this is the circle of Willis. This is the circle of Willis. Let's continue in this thing. So we talked about the left vertebral artery that comes right from the arch of the aorta, which is another anatomical variant that usually is seen in 6% of the population, and this is also called four-vessel arch. And the importance maybe of this four-vessel arch, or this left vertebral artery takeoff from the arch of the aorta, is the fact that this left vertebral artery can terminate as the posterior inferior cerebellar artery, namely the PICA, and we need to know that because the circle of Willis can contribute blood from one side of the brain to the other, especially important when we have something that occludes the blood in one side, so the other side, with its communications with the other side, can compensate for this blockage. For example, of course, in ischemic stroke, embolism, thrombosis, and things like this. So, of course, left vertebral artery is an important finding, even though by itself is not very, very important, but its continuation sometimes comes with termination as the posterior inferior cerebellar artery, not continuing with that circle of Willis, which is important to note. Okay, so after we talked about the normal anatomy of the aorta, and we talked about the variants, and I talked about, when I'm talking about the normal anatomy, I'm talking about the branches coming from the arch of the aorta mainly. Now we're going to talk about is the acute aortic syndrome. Acute aortic syndrome, very important thing, because there are very important complications and things to know. So the next subject is going to be acute aortic syndrome. So let's write it down. Acute aortic syndrome. Okay, so when we're talking about acute aortic syndrome, it's a clinical spectrum with the related diseases that are characterized by damage to at least one component of the aortic wall and present a severe chest pain. What I'm talking about, aortic wall, we have the aorta, and here on its wall, if I just zoom up here, I see three layers: the adventitia, the media, and the intima. Those are the three layers of the wall of, if I'm talking about the aorta, or even the blood vessels. But let's talk about big blood vessels that has those three layers: adventitia, media, and intima. Okay, those are the three layers of the wall of the aorta. Now, acute aortic syndrome, let's talk about three important manifestations, or three important etiologies, or whatever you call it. We have one very important aortic dissection. I forgot an S. Dissection. When I'm talking about an aortic dissection, I'm talking about intima defect, and the blood goes to the blood flow to the media. Okay, to the medial layer of the aorta, of the aortic wall, if you want more precisely. Second thing we're going to talk about is the aortic intramural hematoma. So let's write it down: aortic intramural hematoma. Okay, aortic intramural hematoma. Now, when I'm talking about aortic intramural hematoma, I'm talking about media defect. Media, note, media is in the middle. So media defect, from what can I have a media defect? within the vasa vasorum. Vasa vasorum are the blood vessels that nourish the aortic wall or the blood vessel wall. So medial defect with vasa vasorum, again those blood vessels that nourishes the wall of the aorta, vasa vasorum hemorrhage into the wall. Okay, this is aortic intramural hematoma, and if I want short for intramural hematoma, okay? But we're talking about aortic intramural hematoma. So we talked about aortic dissection and aortic intramural hematoma. Now the third and the last thing under the overview of acute aortic syndrome, we will talk about the penetrating atherosclerotic ulcer. The penetrating atherosclerosis ulcer. And when I'm talking about this, there is a short for it called PAU, penetrating P, atherosclerotic A, and U for ulcer, penetrating atherosclerotic ulcer, which is an intimal defect. So it's an intimal defect as a result of atherosclerotic lesion. Result of atherosclerotic lesion. Okay, this is the third thing called penetrating atherosclerotic ulcer. Okay, now we need to, those are the three main aortic syndromes that we are going to talk about. Acute aortic syndrome that we are going to talk about: aortic dissection, aortic intramural hematoma, and penetrating atherosclerotic ulcer. Those are the three important things that we are going to talk about. Now, when I'm talking about those three, and maybe I can just rotate this, I need to note, especially in dissecting the aorta, I need to note especially in dissecting aorta. No, this is not good. I need to rotate this again. Okay, now I need to note where is the lesion, in which area of the aorta. We are dividing into two areas, two important areas, called the ascending and descending aorta. Ascending aorta lesions, usually treated surgically, and more important hemodynamically because they can more easily cause ischemia. Contrast this with descending aorta involvement, which when is isolated, I mean only descending aorta without ascending aorta involvement, we are talking about a more indolent disease, I mean a more innocent disease, because it usually less cause for ischemia. So when I'm talking about ascending aorta involvement, I'm talking that a treatment, let's call it like this, usually surgical. And when I'm talking about descending aorta involvement, I'm talking about treatment which is usually medical treatment. Usually medical treatment. Yet, you need to remember that when you have an acute aortic syndrome, so let's call it an acute aortic syndrome, don't forget that you need full aorta imaging. Obtain full aorta imaging to look for example, more lesions that you missed, and maybe another lesion even rupture and you missed it. So when you find an acute aortic syndrome of some etiology, I mean dissection, I mean intramural hematoma, I mean penetrating atherosclerotic ulcer, don't forget to obtain imaging of the full aorta itself to look for other pathologies that may be even harder, I mean worse. Okay? So when we're talking about first line imaging, we are talking about, let's call it first line imaging. We're talking about one, non-contrast enhanced CT, non-contrast enhanced CT of the chest, of course, and B is ECG gated CT angiogram of the chest, abdomen and pelvis. Chest plus abdomen plus pelvis. So again, when we find pathology of acute aortic syndrome in ascending aorta, think about surgical intervention. In descending aorta, because it less commonly causes ischemia of end organ, therefore it is more benign in descending aorta only involvement. Consider medical management, but in both cases, obtain full imaging of the aorta. Okay, now let's talk about each aortic syndrome by itself. I mean, we start with the first one. We said that there are three. If you remember, aortic dissection, intima rupture, blood flow to the media, and there's sometimes, should be some re-entry of the intima. We will see this. We have the aortic intramural hematoma, which is a thrombus, let's call it, or lesion in the media, in the middle layer of the vessel wall, and we have the penetrating atherosclerotic ulcer, which is a defect in the intima. So let's talk about each of them in order to a little bit more understand each of them. So we start with aortic dissection, a very important entity. Aortic dissection. This is the first one, as we said before, one of the three that we talked about. Again, dissection, intramural hematoma, and penetrating atherosclerotic ulcer. Those are the three. We are now talking about aortic dissection. So we will start with the image that I will draw to try to explain aortic dissection and what happens in aortic dissection. So I will need to talk about the layers of the blood vessel wall. So we start with just an example or a drawing. This will be a drawing. Okay, here there will be another lesion. So let's do something like this and this and this. Okay. So this is the lumen. Let's call it the true lumen of the blood vessel, the true lumen. And you need to remember this name true because many times true lumen and false lumens are used to describe aortic dissection. True lumen is the true lumen of the blood vessel from its origin. False lumen is the area for the blood flow that should not be. I mean, in the vessel wall, there will be some blood flow because of the dissection, which should not happen, which should not be, because of this is called a false lumen. Okay, so here usually the blood flows normally in the aorta, and those are the three layers in the other side. Those are the three layers that are normal. Just remember that when I'm talking about the three layers, I'm talking about the adventitia, the media, and the intima. So there is the true lumen, we have the false lumen. Here is the intima, here is the media, here is the adventitia. And what you see in aortic dissection, you see that something, and when I'm talking about something, that may be trauma, that may be, I don't know, surgery, something that caused this intima to tear. For example, hypertension, which is the most common even. So let's talk about causes first. So causes for aortic dissection, we're talking about hypertension, which is number one in the prevalence for the cause of aortic dissection. And we have other risk factor except for hypertension, connective tissue disease like Marfan syndrome, drugs like cocaine, and what else? Arthropathy, for example, bicuspid aortic valve, weightlifting, so let's call it 5, weightlifting, other things that may be sudden deceleration injury, so let's call it like sudden deceleration injury. An interesting note is that aortic dissection that is secondary to atherosclerosis is most commonly Stanford type B, and I should tell you what are the Stanford classification before we continue. I talk about where is the dissection. If the dissection, this is the brachiocephalic, this is the subclavian, and this is the common carotid, the left common carotid. Anyway, if the dissection is from the brachiocephalic to a distal part, this is called a Stanford type B, which is also called non-ascending aortic dissection. Now, let's color it in this color. So from here on, we have type 2 non-ascending, which is usually treated, as we said before, medically. Because this is, let's call it descending or non-ascending aortic rupture. Now, when we are talking about a rupture that is from the brachiocephalic or proximal in the aorta, this is called type A Stanford classification of aortic dissection, which is ascending aorta involvement. It can involve also the descending the arch of the aorta, but it must start proximally to the brachiocephalic to be called Stanford A. Stanford B starts brachiocephalic or distally. This is the difference. Ascending aorta involvement, usually this is treated surgically. Usually this is treated surgically. So when I'm talking about aortic dissection, and this is important, where is the aortic dissection? The ascending aorta, descending aorta. We have the causes or the risk factor: hypertension, connective tissue disease, atherosclerosis disease, bicuspid aortic valve, cocaine, or weightlifting. Anyway, what we see is, starting with this, there is an intimal tear. As you see right over here, there is an intimal tear. And this, what you see right over here, it is called a flap, intimomedial flap. So let's call it a flap. Let's call it a tear in the intima. Then the blood can also go right over here. Instead from flowing in the true lumen, it goes to flow in the media of the rupture, I mean in the false lumen. Now, the blood flow in this false lumen is slower, so it has more tendency to form a thrombosis. So there may be thrombosis in the false lumen. There is also here, what you see here is another tear that lets the blood exit the false lumen. This is like a re-entry tear because it lets the blood re-enter the true lumen from the false lumen. And it may even obstruct the outflow and leads to even higher pressure in the false lumen. Anyway, those are the parts of the aortic dissection. Dissection in the intima, let the blood flow inside the false lumen. There the blood flows slower so it can create a thrombosis, and then the blood may go again or back again to the true lumen throughout another re-entry tear in the intima layer. But this area is usually around the media part of the aorta. Now, the false lumen is usually even bigger than the true lumen, and remember that it has lower contrast density on atrial phase compared to the true lumen, especially when you think about a thrombosis that may happen there. So we need to look for this. Those are the signs. And don't forget to look where is it on the aorta, ascending aorta or non-ascending, type A or type B Stanford classification for aortic dissection. Very important for management decision. The next thing that we are going to talk about is intramural hematoma, IMH of the aorta. So intramural hematoma or IMH, intramural hematoma of the aorta. Let me just bring some water because it's very hard to do talking without some water. So 1 second, I am bringing some water. Okay, so I brought some water and now we can continue. Let's continue with it. So intramural hematoma, again, I'm talking about especially the aorta, but let's define how it looks. Or maybe just a minute, let's think about how dissection of the aorta looks on imaging. So let's think about axial imaging, and I'm looking on axial imaging of the aorta. I may see some, for example, let's call it a flap that separate the aorta between, let's call it maybe the fourth lumen right over here and the true lumen right over here. It depends on where is the lesion and where the blood happens to be. But you can see this flap that separates the true lumen from the fourth lumen in aortic dissection. And this is important because it will be different in intramural hematoma. But in order to understand the imaging findings, we need to understand the pathogenesis of intramural hematoma, and this is exactly what we are going to do. Again, we will draw the blood vessel with its walls, and then look on what happens. So we have the blood vessel, here it is. We have the wall of the blood vessel. Maybe I did it too small. This is the wall. Again, there are the adventitia, the media, and the intima. What happens, for example, is that there is a lesion. For example, rupture of the vasa vasorum, which are the blood vessels that nourishes the wall of the blood vessel, of a bigger blood vessel. So there is a rupture of the vasa vasorum, which creates some, for example, here, you see that the intima is complete, and I'm not talking about a rupture in the intima, but a lesion in the media. So there is a rupture of the vasa vasorum in the media and hemorrhage in the media. So here you may see hemorrhage that will become clot. There may be some associated aneurysm. So here you may see something like this, or so all of this is like a pouching. But again, remember that the intima is always intact. The intima in intramural hematoma should be intact, even though you may say that intramural hematoma can continue to become a dissection, and dissection, of course, as we saw, has rupture in the intima. Sorry for this. Okay. You can think about intramural hematoma, maybe it's more appropriate or more hinting to say non-communicating dissection, because there is non-communication between the false lumen and the true lumen, because the intima is intact. Therefore, there is no communication between the inner lumen of the aorta, where true blood or normal blood flow happens, and the false part, let's call it the area in the media that hemorrhaged from, for example, rupture of the vasa vasorum. And then when you are looking on this blood vessel, what you will see, if we are cutting it like throughout it, you will see here the normal aortic lumen, and around it you will see, for example, right over here, some crescentic shape hemorrhage. And if you're looking on imaging, you will see maybe exactly like this, maybe even more, and it just will surround the true lumen. This is a crescentic more way. Compare it to the dissection that looks like this. This is a dissection. This is an intramural hemorrhage. So this is the idea. Let's call an intramural hemorrhage a variant of dissection. The clot is in the media without a flap that connects the intramural hematoma with the aortic lumen. Usually intramural hematoma, as we said, is a rupture of the vasa vasorum, small blood vessels that supply the aortic wall. And when we're talking about etiologies quite similar to aortic dissection. We are talking about hypertension, we are talking about trauma, and we are talking about those things. Now, clinically, it may be just the same to dissection clinically. I mean, chest pain, back pain. Now, when we're talking about how to approach the treatment, it's very similar. It's very similar to dissection. I mean, in regarding to ascending vs descending aorta involvement regarding the treatment. Now, the protocol, the imaging protocol, it depends on what is the risk and what is the probability for intramural hematoma. If you're talking about high-risk patients, you will have, so first recommendation based, let's call it the Stanford classification, like in aortic dissection. Now, imaging protocol based on the population. When I'm talking about high risk, I'm talking about a unenhanced phase, unenhanced phase, specifically to evaluate the intramural hematoma. After this, we're talking about CTA of the chest, abdomen, and pelvis, chest, abdomen, and pelvis. This is on high-risk patient. Now on low-risk patient, CTA of the chest. I'm talking about CTA of the chest. Looking at the CTA of the chest, if there is wall thickening, non-contrast scans 6 hours after can evaluate for intramural hematoma versus vasculitis. So look for wall thickening, and now 6 hours later, if there is wall thickening, which may tell you that there may be some intramural hematoma, but also things like vasculitis may come with a wall thickening of the blood vessel. So 6 hours later, not at the same time, you are talking about non-contrast and hence CT, which can evaluate for intramural hematoma versus vasculitis. Okay, this is the idea of what is going on. Oh, I must Okay, so we can continue. So we talked about the protocol that should be used for the patients. So when we're talking on the key imaging finding of intramural hematoma, imaging findings of intramural hematoma, I'm talking about a peripheral hyperattenuation. So let's do a list. Peripheral hyperattenuation. I mean, in Hounsfield units, we are talking about 60 to 70 Hounsfield unit. As we said, crescentic shape. And like this, you see this crescentic shape. This is the intramural hematoma. The crescentic shape. Now, it is best seen, as we said, on non-contrast enhanced CT. Non-contrast enhanced CT. This is why we are doing the non-contrast enhanced 6 hours later if we suspect this after CTA. Another important finding to think about is displaced intimal classifications. So look for the classifications that are displaced. Again, we will appreciate it the best on a non-enhanced CT. Okay, we can close it. This is not helping me. So let's continue. Okay, so those are the findings that you can see on imaging, non-contrast enhanced imaging, looking for intramural hematoma. We're talking about crescent shape, hyperattenuating peripheral lesion, 60 to 70 Hounsfield units, and also displaced intimal classifications that are another important finding, imaging finding, and hey for CT. Okay, let's continue. Let's talk about ulcer-like projection, which may be found on this case. We're talking about ulcer-like projection, which is a contrast enhancement extending from the aortic lumen into the an IMH via visible communication. It is a poor prognosis. Now let's try to show you how ulcer-like projection may be seen that has a poor prognosis on ulcer-like projection on IMH. An intramural blood pool also presents focal contrast enhancement within an intramural enhancement, but has a nearly imperceptible communication to the aortic lumen. Its prognosis is unclear. Anyway, what we're talking about in ulcer-like projection is like this. We have the wall of the aorta. We have this media where, for example, intramural hematoma lies. Okay, this is the area of an intramural hematoma. Now this is the area of the, let's call it the true lumen, and this is the other blood wall of the aorta. Now there is like this thing, ulcer-like projection. This is the ulcer-like projection. From the true lumen, there is like a projection onto the intramural hematoma. This is an ulcer-like projection, which is focal. You see it in imaging like a focal enhancement from the aortic lumen into the intramural hematoma via a communication. Usually, by the way, the neck of this projection is usually more than 3 millimeters. More than 3 millimeters. Now, if we look on it on axial image, we can see something like this. We can see something like this, and maybe I'll do it area eraser. This is like the aorta. Now, this is the crescentic shaped, let's do the crescentic shaped intramural hematoma, something like this. Now here you will see a pouch. Again, the neck is at least 3 millimeters, and some pouching like this. Okay, and this is contrast enhanced, like a focal in the more hypoattenuating area, and this is the aorta. Okay, and this is ulcer-like projection. Ulcer-like projection. This is the intramural hematoma, and this tells you that there is a poor prognosis. Now let's talk about another thing, which is intramural blood pool. Now, intramural blood pool has an undetermined prognosis, but what you may see, this is the ulcer-like projection, what we showed here. This has a poor prognosis, and tell you that the patient is not in a good shape probably, or this intramural hematoma has a very poor prognosis. Now, there is another thing that is less known what is its prognosis, which is called a blood pool. Now, this blood pool looks something like this. If you have the true lumen of the aorta and you have this crescentic shape intramural hematoma, you may see some things like this. There may be some communication here and communication here to the outside, even with aortic branch. And this is an area inside the intramural hematoma. This is why it's called like a blood pool. Now, what we can see on axial imaging, it will be like this. This will be the same on axial imaging, the same exactly, almost exactly. Some hyper intense lesion like focal enhancement, let's call it enhancement, so the blood vessel can go right over there. There is some focal enhancement on the intramural hematoma. Intramural hematoma is right over here. This is blood pool. Again, its prognostic factor is not really known. Now, the next thing that we're going to talk about is the third acute aortic syndrome, which we talked about, penetrating atherosclerotic ulcer. Now, penetrating atherosclerotic ulcer. Penetrating atherosclerotic ulcer. And when we are talking about penetrating atherosclerotic ulcer, again we will talk about the aorta, where with its wall. So here is the adventitia, and we have some like this, and we have some media right over here, and we have some, and like let's do it like this, and there is some, I don't know, atherosclerotic lesion that is penetrated, as you can see here, and the blood can flow, but it can push the adventitia, the media, like this. And here is the lumen, and blood can flow right over here. This is the aortic lumen, and this is the other wall, normal wall of the aorta, within intima, media, and adventitia. Okay, adventitia, media, and intima. Now, let's talk about a little bit about the penetrating atherosclerotic ulcer pathogenesis. We have some atherosclerotic plaque. This is the plaque. This is the plaque. It penetrates the intima. As you can see, it penetrates from the inner part of the aorta to the away from the intima, more than the intima. Now, this plaque ulcerate, you can see here, there is some hole in it. Therefore, the blood can go to the media. Now, the media can enlarge, and there is some aneurysmal formation, as you can see right over here. So, when we look on imaging, what we will see is something that called like the pouch that we just saw when we talk about ulcer-like projection. What we will see on imaging is that if you will see on coronal imaging, if this is the aorta, you will see some like this. So you will see blood that is also here, but there is no intramural hematoma. On axial images, this is on coronal images, coronal, this is the ascending aorta on coronal images, or on sagittal. Yes, it's sagittal images, I think. It's more correct to say sagittal. This is on sagittal imaging. Now on axial imaging, we have the aorta right over here, and we have some pouching like this. So you can see that penetrating atherosclerotic ulcer is, bottom line, it's like a focal defect in the intima that occurs at the site of atherosclerotic plaque. We need a plaque that penetrates, so the idea is a focal defect in the intima in the area of the plaque. And we may see saccular aneurysm formation. And when I say saccular aneurysm formation, saccular aneurysmal formation, we also talk about a berry aneurysm, Spherical outpouching of the arterial wall most commonly occur in a bifurcation, the cerebral bifurcation, along the circle fluid. The ventricle has a narrow neck connecting the sac to the parent wall. Saccular aneurysm. Okay, anyway, on imaging, you see how it looks. It looks like a pouch or outpouching from the aortal lumen, contrast field outpouching beyond the expected contour of the aortic wall. You may think it's maybe ulcerated atherosclerotic plaque and not penetrating atherosclerotic part, but when it expands beyond the contour of the aortic wall, you need to think about a penetrating atherosclerotic plaque and not just ulcerated athe plaque. Now, to differentiate it from what we said about IMH with the ulcer-like projection, which seems very similar, you need to understand that ulcer-like projection, we are talking about it in the context of IMH, intramural hematoma, and therefore usually in intramural hematoma it won't be on the initial imaging, and those patients may even be, the patients with intramural hematoma may be even without atherosclerosis. So to differentiate between the two, think a little bit about patient and what prior imaging the patient has and what we are looking at. Are we looking on intramural hematoma or are we looking on outpouching from the aortic lumen without a IMH, without intramural hematoma? Now, maybe last thing is to remember that if we see any of those things that we talked about, aortic dissection, intramural hematoma, penetrating atherosclerosis, ulcer, remember that many areas of the aorta may be damaged. And when we did imaging, we may capture only one part of the problem. Therefore, there may be more pathological areas. Therefore, when we see any of those acute aortic syndrome, aortic dissection, intramural hematoma, penetrating atherosclerosis, ulcer, always think about image all the aorta to all its length to look for more pathologies, to look for more ulcer, to look for more dissection, to look for more hematomas, intramural hematomas. Don't forget, maybe image the whole aorta when one lesion is found. And when I'm talking about one lesion, I'm talking one of the three acute aortic syndromes. So this is it about acute aortic syndrome, aortic dissection, intramural hematoma, and penetrating atherosclerosis, ulcer. Okay, so except for this, we also talked about the aorta anatomy and the variants of the aorta. The next thing we are going to talk, I'm not sure we're going to talk about it right over here, but we need to talk about traumatic aortic injury. I mean aortic trauma, minimal aortic injury, pseudoaneurysms, and then we're talking about thoracic aorta, thoracic aortic aneurysm, inflammatory and infectious disorders like giant cell arteritis, infectious otitis, Takayasu arteritis, occlusive disorder like aortic coarctation, subclavian steal syndrome, superior vena cava, like superior vena cava obstruction, congenital anomalies of the superior vena cava, abdominal aorta, abdominal aortic aneurysms, aortic rupture, abdominal aortic aneurysms, endoleaks, abdominal aortic disorders, mesenteric and pelvic vessels, splenic artery, renal arteries, aorta, celiac trunk, SMA, external iliac arteries and internal iliac arteries. But I think for now we are good to go. So we talked here about anatomy of the aortic branches at the arch of the aorta, brachiocephalic, left colon carotid, left subclavian, vertebral arteries, internal mammary arteries, and all the variants, or maybe the major variants. Then we talked about acute aortic syndromes with the three main syndromes: acute aortic dissection, intramural hematoma, and penetrating atherosclerotic ulcer. And we talked about the Stanford classification, which is important for treatment based on type 1 or type A or type B, where type A is the surgical one that is treated surgically usually, and we are talking about ascending aorta involvement, and the treatment is most commonly surgical. We're talking about descending aorta, treatment is more commonly medical, and the reason is that ascending aorta more easily cause ischemic complications compared to descending aorta involvement. Now, when I'm talking about ascending and descending, remember that the cutoff is around the brachiocephalic. Brachiocephalic or distally, we're talking of Stanford type B, which is medically treated, and brachiocephalic proximally to the brachiocephalic area, we are talking about something, let's call it something that starts between the brachiocephalic trunk and the left subclavian artery, and not involving the ascending aorta, proximal to the brachiocephalic trunk, is considered B. So brachiocephalic artery is like the border. Everything distally is the Stanford type B, everything proximally is Stanford type A, and surgically type A, medically usually is type B, and this classification is important therefore. Okay, so here we will finish, or just for now I will finish it, and maybe we'll continue in some minutes, maybe in another time. We need to talk more about traumatic aortic injury and more about the aorta. We didn't finish about the aorta, but for now this is enough. Thank you very much. If there are any mistakes or corrections, please tell me. I have nothing else to say. I mean, I have what to say, but not for now. Thank you very much, and that's it.